Today, we're covering the general management strategies in shock. No matter the type of shock or the stage, some core treatments apply across the board. These include supporting the respiratory system with oxygen or mechanical ventilation, restoring intravascular volume with fluids, using vasoactive medications to support blood pressure and cardiac function, and providing nutritional support because shock creates a massive metabolic demand. All of these therapies require close collaboration between the nurse, the provider, and the entire healthcare team. Fluid replacement. Fluid replacement, also called fluid resuscitation, is given in all forms of shock. The goal is to improve cardiac output and oxygen delivery. Types of fluids include crystalloids like normal saline and lactated ringers, colloids such as albumin, and blood components like packed red blood cells, plasma, or platelets when needed. Crystalloids. In emergencies, the best fluid is usually the one that's available. Isotonic crystalloids are most commonly used because they closely match the electrolyte concentration of plasma. Normal saline, or 0.9% sodium chloride, is frequently used, but large volumes can cause hypernatremia, hypokalemia, and metabolic acidosis. Lactated ringers is often preferred because the lactate is converted to bicarbonate, helping buffer acidosis. Hypertonic saline, such as 3% sodium chloride, is not recommended because it doesn't improve outcomes and may cause complications. One downside of crystalloids is that not all of the infused volume stays in the intravascular space. Some diffuses into the interstitial compartment. This means larger amounts may be needed to restore perfusion. Care must be taken. Too little fluid worsens hypoperfusion, but too much fluid can lead to pulmonary edema, acute lung injury, intra-abdominal hypertension, or abdominal compartment syndrome. Abdominal compartment syndrome. Abdominal compartment syndrome, or ACS, happens when excess fluid leaks into the abdominal cavity. Pressure rises, impairing venous return, preload, and cardiac output. It also pushes the diaphragm upward, making breathing difficult, and reduces kidney and gastrointestinal function. Normal intra-abdominal pressure is between 0 and 5 millimeters of mercury. A pressure of 12 millimeters of mercury or more signals intra-abdominal hypertension. If full-blown ACS develops, surgical decompression is often required. Colloids. Colloids contain larger molecules that stay in the intravascular space longer. They expand plasma volume by pulling fluid in through oncotic pressure. The most common colloid used is albumin, which is derived from human plasma and heat-treated for safety. While effective, colloids are expensive and haven't been shown to reduce mortality compared to crystalloids. Side effects are rare, but can include anaphylaxis, so nurses must monitor closely. Monitoring. During fluid replacement, traditionally, central venous pressure, or CVP, was used to estimate fluid status. A catheter is placed into the subclavian or jugular vein, with the tip near the right atrium. However, research shows there is no direct link between CVP readings and actual circulating volume. So today, CVP is not considered a reliable measure of fluid responsiveness. That said, central lines remain important for delivering large volumes of fluids, giving blood products or vasoactive medications, and sometimes monitoring oxygen saturation of venous blood. When central lines are placed, nurses play a key role in preventing central line-associated bloodstream infections, or CLABSI. This involves evidence-based bundle practices like strict hand hygiene, maximal sterile barrier precautions during insertion, chlorhexidine antisepsis, choosing the best catheter site, and reviewing line necessity every day. Vasoactive medication therapy. When fluids aren't enough to maintain perfusion, vasoactive medications are added. These drugs act on alpha and beta adrenergic receptors to stabilize hemodynamics. Alpha receptors cause vasoconstriction in the skin, kidneys, and gut. Beta-1 receptors increase heart rate and contractility. Beta-2 receptors cause vasodilation in skeletal muscle and bronchodilation. Depending on the situation, the provider may order inotropes like dobutamine or dopamine, vasodilators like nitroglycerin, or vasopressors like norepinephrine, epinephrine, or vasopressin. These medications are potent and must be titrated carefully, usually through a central line. Vital signs must be monitored at least every 15 minutes until stable. Important safety note: vasoactive medications should never be stopped abruptly. Doing so can cause dangerous hemodynamic instability. When discontinuing, doses are tapered gradually with close blood pressure monitoring. Nutritional support. Shock drives a catabolic state where energy needs skyrocket. Patients may require more than 3,000 calories per day. Glycogen stores are quickly depleted, and the body starts breaking down skeletal muscle, prolonging recovery. Early enteral nutrition is preferred over parenteral feeding. Enteral feeding maintains gut function, reduces infection risk, and improves outcomes. Even when gastric residual volumes are high, current evidence says that doesn't necessarily predict aspiration risk. With careful protocols, feeding can usually continue safely. Stress ulcer prevention. Critically ill patients are at high risk for stress ulcers due to poor perfusion of the gastrointestinal tract. Medications like antacids, H2 blockers, or proton pump inhibitors are prescribed to reduce gastric acid and protect the stomach lining. Final takeaway. To sum it up, all forms of shock require oxygen support, fluids, vasoactive meds when needed, and nutritional support. Crystalloids like lactated ringers are first line, but over-resuscitation can cause serious complications like pulmonary edema or abdominal compartment syndrome. Central lines and vasoactive medications require careful nursing oversight, especially infection prevention and safe titration. And don't overlook nutrition and GI protection. These make a major difference in outcomes.